Okay. So to start with, we're going to go over kind of what the article is about so that we're all coming from the same place as we go through it.
Okay.
So, in my understanding, the study was to try and find more solid predictors and risk factors other than the really old ones that we've been using for years to figure out the mortality rate within 5 years of being diagnosed with hypertrophic cardiomyopathy.
Mm-hmm.
Did you guys get that?
Yeah.
Yes.
Yeah, I did. So then it went off of these 8 variables, right? So like age, family history, wall thickness, fractional shortening, all that stuff in table 1.
Mm-hmm.
Yeah.
Okay.
Those were the original things that they did, like that they searched for.
Right.
But this one, wasn't it also to see if ICD and implantable cardio overture defibrillator would also be a good, not cure, but
like way of coping with it?
Yeah. For having hypertrophic cardiomyopathy.
Yeah, so the way I understood it was there's that, like, equation that they had,
Mm-hmm.
and then, like, depending on where not your answer, but, like, depending on where you fell, like, after solving that equation would determine, like, your best steps of procedure and, like, whether or not, like, because it talked about here, like, I don't remember exactly where it was, but it talked about, like, the cost versus the benefit of the ICD, because it was saying that, like, after 5 years, like, some people were complaining about, like, shocks given when it wasn't needed and stuff like that. So if you don't really need an ICD, is it worth getting it to be on the safe side, or is that going to lead to more problems down the road?
That was kind of one of my questions was, it seems like they're trying to reduce the risk of kind of like false positives. So implanting the ICD in people who probably didn't need it. So do you think the benefit of that kind of outweighs the risk of implanting people that are like false negative, where you don't think you need it and then you give someone an ICD?
So, what I received from it that I think it is okay is the way I took it, only because I know someone that died from having a hypertrophic cardiomyopathy, and it was like on a basketball court, random.
Whoa.
Yeah, and because they didn't know that he had this, of course, and so I feel like, in his family, it actually turned out to be that all the males have hypertrophic cardiomyopathy, but none of the women, which is very interesting. But anyway, I feel like if one that is like not necessarily in the equation, like in the parameters of needing it directly, like as much as someone else, I think if they had the implantation, it wouldn't be as bad, of course.
Right.
Maybe if there's a way they can go about regulating it, because I feel like it shouldn't just be like, all right, I'm gonna give you a shock, you know what I'm saying? Like, if it's set correctly, then I feel like it should not be as bad. And granted, I'm sure it's not comfortable at all, and other things that people complain about later, but
and plus,
I feel like the risks don't outweigh it.
Yeah, and then plus, like, they're complaining, so they're still alive.
Yeah.
As opposed to if they get SCD and then they're dead.
Yeah. Agreed.
It's better to get the implantation even if you don't need it, as opposed to like needing it and not having it.
Yeah,
exactly.
Are those implants like recalibrated and stuff like that, like after a certain amount of time, like, because if that's an issue, like, why don't they just calibrate them like before, if they're having complaints like after 5 years, like, why not? Do they do like a yearly checkup? Like, I feel like,
because it talked about the patients recruited were ones that all patients planned clinical reviews every 6 to 12 months or earlier if there were changes in symptoms. Sorry, I was looking for it and found it. So I think, like, they recruited patients by the ones that actually, like, were getting regular checkups.
Gotcha. Okay.
As opposed to, like, every once in a while and hoping nothing happened, I guess.
Okay.
I found it interesting that this was for the group was, like, 16 and older.
Yeah.
And I've always heard that this is, like, a huge thing with, like, younger populations and, like, the high schooler that drops it on the basketball court, like that kind of thing. So I thought it was interesting that it was that older segment.
Yeah. Plus, because younger kids, they aren't scanned, they aren't tested for that stuff early on because they aren't expected to have heart problems and stuff like that. So it's interesting that.
And I think it came out that the people actually in their study, nobody was actually younger than, I think, 30, honestly, if I'm not mistaken. Yeah. I think it was like 48, 43, 57, plus somebody's like 15, 16.
That's still...
Yeah. So it's still pretty old. It was just very interesting.
It'd be interesting to see like a follow-up on this, but with the younger population.
Yeah.
I mean, I know it'd be harder to find like a sample size, but...
Because, like, in the limitations, I always like reading limitations, because I think it's but it says, like, you should only use these, like, clinical prediction rules for groups that are, for patients that are similar to the people in the study, and that you shouldn't use it for pediatric patients, elite athletes, or individuals with metabolic diseases. So, like, it seems like this is for a very limited group, but when I was reading through it, it sounded like it was for, like, all of these people.
Yeah.
And I think that was one of the points that they wanted to make, was to make it broader, but I'm like, really didn't do that. But for the group that they did, that run their study on, it turned out to be, you know, beneficial, but yeah, that was interesting.
Yeah.
Do you guys think that, because they said that these different rules, like, other than the ones that were already presented, or so that you could individualize the risk to each patient. Do you think there are ways that they could have, like, gone about, or, like, in further study could individualize it more, like, for the younger population or the elite athlete? Like,
I don't know about like the younger athletes more, but it did talk about how it didn't take into consideration like ethnicity and stuff like that. So they could like branch off a little bit and go by like race or something like that, just to see if there's like a pattern or something. But
yeah, I'm trying to find that. So I did find it interesting that they had it so limited. I wrote it somewhere. Who knows? But
in this 12-page article,
it was like, I was thinking, could they also look more into their economic background as well?
Yeah, I wrote that down too.
Would that be something they should check out?
Yeah, it was like right here. It was talking about like under the future development of the model, it says like sex and ethnic background as well as environmental patterns such as social deprivation and access to healthcare should be investigated to improve the prognostic performance of the model. And that's something too, because it's like if they need an ICD, what if they can't afford it?
Yeah.
Then what? Like what good is this study if like the means of it don't apply to people?
Agreed.
So
it's like, hey, you should get this, but your insurance doesn't cover it.
Yeah, so it's just kind of like your SOL.
Yeah.
it's interesting too because these are in like, it's in European countries.
Yeah.
And a lot of these countries actually do have like the model that are like that the Affordable Care Act was modeled on. They have compulsory insurance. So like they at least have like coverage for catastrophic. So like this would be catastrophic. And probably...
Is HCM, though, considered catastrophic if it hasn't reached that SCD point, though? Or is it just, like, a warning sign? You know what I mean? Like...
It seems like these people were, like, recruited because they found out they had hypertrophic cardiomyopathy.
Yeah.
And I feel like that's not something that you just, like...
Casually.
Pick out in a regular physical. So, I guess the way I read it was these people, like, had, like... unexplained syncope or something that made tests more relevant to like figure out that they had it.
Yeah.
So it'd be interesting to see how this would work in the US where like we have insurance that's really weird. We've got a higher rate of obesity. We've got a higher rate of inactivity.
Yeah, that was one of my questions actually. I was like, do you think it'd be different in the US due to like lifestyle differences? Like they're walking around a lot more, they're on their feet a lot more. Like, what kind of effect would that have on this study as opposed to like if you're like what you just said, like if we did this in the US?
Would this study been able to be run in the US though? I feel like it's kind of. I don't know. We're all reading it. Maybe I misunderstood.
Well, and that's one thing as like clinicians, like. That's a really good point because it's like if this is only applicable in Europe, the vast majority of us aren't going to Europe to become athletic trainers.
Yeah.
So
yeah, because like to get the characteristics that they pulled out, like it takes a lot more testing to figure out like the length or the width of the wall of your heart. Like, that's not something that comes with an everyday checkup.
No.
I also thought it was interesting when they were discussing the methods, they did, like, people who actually, like, reached the endpoint, as they called it, which is kind of weird.
Yeah.
But they would look at those, like, the event that was the sudden cardiac death. They'd interview the witnesses and the doctors, and then it was like, here it is, the primary endpoint of SCD or an equivalent event. Sudden cardiac death was defined as a witness sudden death with or without documented VFib, or death within 1 hour of new symptoms, or nocturnal death with no antecedent history. Like, that just seemed like kind of arbitrary. Like, we're just gonna like, I don't know. Because to me, a nocturnal death, like, that could be someone had a heart attack in the middle of the night.
Right.
Like,
But
it just was interesting to me, I guess.
Yeah. I guess you just kind of got to take it with a grain of salt. Like, if they have HCM, odds are, if they're dying at these, like, lower ages, as opposed to, like, 80s, you got to like, kind of contribute it to HCM.
It said they interviewed, like, the doctors and the witnesses to the death, which I feel like if you're interviewing a witness to, like, a person dying, that might not be the best data.
Yeah.
Like, the doctor I would understand, but...
especially if they don't have, like, a medical background or anything.
Yeah.
Interviews with witnesses and relatives, I would not. I don't think I would be able to, like, be in that discussion if I witnessed something like that.
It was also curious to me how, I think they said at one point, it was either a sudden cardiac death or something, like, equivalent. I'm like, what is equivalent to a cardiac death? Like, let's see. Yeah. Oh, here we go.
Oh, yeah.
Aborted SCD during follow-up and appropriate ICD shock therapy were considered or equivalent to SCD.
Is that like if they go into, like, cardiac arrest, do you think?
The aborted sudden cardiac death?
So right before they die?
Yeah. I feel it coming.
Like, yeah, I didn't understand that. Like, is that somebody passed out was going into sudden cardiac death and then, like, the EMTs revived them? Like... I don't know.
There's
just so many gray areas. I feel
like how does the ICD work? Because it says it gives them that shock therapy, which that makes sense to me.
Yeah.
But I'm just like, when does that even kick in?
That would have to be timed so perfectly. I feel like.
Yeah.
In order for it to. I mean, I guess that's what it's for, but I don't know.
Which is probably why people were getting shocks, like, when they didn't need them. Like, maybe they were, like, at really good rest. You know what I'm saying?
Yeah.
And then
the
thing
monitor was just like, problems.
Yeah. That would be interesting. One of the things that I also thought was interesting was when they were talking about how this is the first, like, validated study that came up with the CPR. Do you think that, like, physicians would take into account, like, or, like, I'm trying to, like, figure out how to say this, weigh the risk factors from the original, like, hard and true risk factors differently than they weigh the risk factors that came from the CPR?
So, like, would they even use it? Or,
like, because for the comparison of conventional risk factors, that area, it said that, it said, to compare the risk model developed in this article with contemporary clinical practice, a risk score was constructed with the value of 0 if no conventional risk factors were present, 1 if conventional risk factors were present, and 2 if 2 or more conventional risk factors were present. Do you think, like, as a physician, you would look at the clinical risk factors first? Like, the conventional ones, and then look at this one?
Yeah, I feel like I would. Especially since this one has such a narrow group. Like, that stands out to me.
Yeah.
Especially as a clinician. Like, I don't think I, for lack of better words, would take this as seriously. You know, especially as athletic trainers, I don't think our athletes would be as old, depending on the situation.
Right.
Depending on, you know, the setting and such. And not just athletes, of course, because we'll have general...
Right. Like patients.
Patients and stuff, too. But... it's kind of like if nothing before this, I mean, if everything before this worked, you know, I feel like I take that more seriously than I would just.
And like, as like a future athletic trainer, I would rather cover all of my bases and be completely wrong and then not have an issue than like me say like, it's not as important. Like everything else we did before worked, you know, and then not cover something and then have it be a real problem. Like I'd rather like better safe than sorry.
Yeah. Also, as clinical athletic trainers, we would have to like if we're working outside of like a PT type clinic setting. This isn't for anyone under 16. So
right.
It wouldn't be for your high schoolers or your middle schoolers. And it's not for elite athletes, which some would argue that college athletes, especially D1, those are elite athletes. Like,
have we seen IPFW? I'm kidding.
Okay, wow. We'll not get ourselves in trouble. But like, this really wouldn't. The newer CPR wouldn't be nearly as effective for us. Right. As the
but like in a PT setting, this is perfect. This is right up their alley.
Agreed. Yeah. Were there any other parts of the article that you guys wanted to discuss or had questions about? Because it was pretty challenging.
It was difficult.
I will say I liked how organized it was. It was really difficult to understand.
There were a lot of numbers, a lot of abbreviations. Yeah. We got through it, guys.
That equation, that really rough, long equation. That does the probability.
Yeah, probability?
Probability of, I think it was like the end point in 5 years. I just don't like the end part.
I really liked like bringing it back to patient-centered care and like primary intervention and stuff like that. I liked that, like, in this article, it had that website that you could go to, and you could, like, type in your information and see, like, your SCD risk. I really liked that because, I mean, not a lot of the public reads these articles. Like, I'm just being honest.
Yeah.
But, I mean, it was really cool to, like, bring it back to, like, an everyday person. Like, hey, you can check this out, and this is, like, stuff that you can do to, like, see your risk and, like, if you are at risk, what you can do for it. So it brought that, like, awareness and education to it.
Yeah.
So that was really cool. And it's a shame that it's, like, 8 pages into the article as opposed to, like
at the top.
Right up top. Like,
in the intro where it's still in
and, like,
English.
and, like, before reading this article, like, I didn't know that I could do that. And, like, that's really good information to, like, pass out to your family and just be like, hey, because if someone in your family has it, it's, like, a genetic thing. Yeah. So that's, like, important. So.
Agreed.
I just liked that they had that, like, educational aspect to it. Like, hey, this is something we all can kind of do. Like, you can check it out. And then I think, like, on the back, like, the last couple pages, like, it had it here, like, for supplement stuff. I liked that aspect of it.
Especially if you have, like, when you're going through the history at the beginning of the year, like, of all the paperwork you have to fill out for your athletes. Like, if somebody says, like, my grandpa died at, like, 35.
Yeah.
Like, you can go and look and be like, all right, here is this, like... Let's go through this together.
Right.
Let's see if your risk is high as well.
Right.
That's not.
It doesn't even have to be an individual thing. Like, as athletic trainers and PTs and stuff like that, we could use that.
Yeah.
To just be like, hey,
let's look at this together.
I mean, like, a doctor is always preferred to a website, but like, if that's all you have, that's all you have. Yeah.
Yeah, and education is always important, especially with genetic diseases and stuff like that,
and especially something as serious as this. Like,
yeah.
So, I liked that aspect of this. We hit both of my questions. So, we talked about a lot. We did age limit. We covered that, right?
Mm-hmm. Yep.
Covered the lifestyle differences.
Mm-hmm.
What else?
Because we went over pretty much the questions that I had, too.
Okay.
Right.
Did we cover it all?
Cool. I think we're good.
Like mine too are same day as yours.
Perfect.
Awesome.
Okay. I'm ending this video then. Bye.